there isn't really much else I think we can do besides kind of show you the language that ended up in the final rule and give you at least our take on what we think the most important aspects of it are for state APCD. So that's the purpose and the goal that we have today. It can absolutely and probably should be conversational. So I think if anybody wants to jump in and talk about anything that they have done within their organizations or any guidance that you have all received from, legal counsel or other folks within your organization, please feel free to jump in. Again, this is, what we've tried to do here is go through the entire rule and to the extent possible, pull out the pieces that we think are most important to you all as folks who are doing work on the state APCD side and hospital discharge data side as well. There is direct reference within the rule around discharge data as well. So, if you're running a health data program, obviously this rule is relevant to you. And again, what we've tried to do in the course of this is highlight the things that we think are most important. I do think it's important for us to be very clear with folks that at the end of the day, we're not lawyers and we're not legal counsel. And so you'll obviously, probably need to get some additional guidance from other folks besides us, but at least hopefully this will give you some direction that you can give other folks in your organization who are likely going to be looking at this on your behalf or along with you. So any questions or concerns or suggestions from folks before we get started? No, you're all just anxiously waiting to hear about this. Okay. So the rule that we're talking about is the one that was published on February 16th of 2024. So that's the version that we're talking about today. You'll notice within it, within the presentation, that's us. You all know about us. Within this presentation, which we will share with everyone, there are page references to the pages that the text that we will talk about exists on. And can you all see this version of the final rule, or am I just presenting the PowerPoint? I can never tell in Teams.
Now we're seeing the Word document.
Okay, great. Great. So these are the page numbers up here that are referenced to when I go through this presentation. So if you go into the Federal Register and you pull the PDF of the final rule down, these are the page references that I'll be referring to. And Emily, did you have a question? I see a hand up.
I did not. I was trying to react thumbs up. Never mind.
Oh,
thank you.
All right. Well, we tried. If anybody has a question, you see that the hand function works, and we will actually see that. So feel free to use it. So, as I said, this the presentation that we pulled together is literally, text that's pulled out of the rule, and we'll do a little bit of context setting to explain why we think these particular sections may be relevant to you. And again, there were direct references in the comments around the rule that we think are important language for you all. So just as a starting point, in the final rule itself, which I'm going to pull my paper copy of important pages down because that's helpful to me. And I apologize for those of you who already know all of this, but when a final rule is published, there's introductory text that the agency publishes before, as a precursor to the actual language that it tells you is in the final rule for final rule changes. So much of what we're going to talk about actually pulls from the preamble language and the information that is resultant from the comments that were submitted to SAMHSA and the responses that they make to those comments. A lot of the explanatory rationale that SAMHSA has for why it did or did not make actual rule language changes is explained in the early part of the comments and the response. So a lot of what we're going to talk about is actually what SAMHSA reflects, not necessarily in what appears in the actual final rule language. So if you go find this rule, the final rule language will not have a lot of what you'll see on screen, because what we're pulling from is really SAMHSA's explanatory language to basically say we did this with the rule or we didn't do this with the rule. And that explanatory language is incredibly important, because what it really does is sets what SAMHSA's intentions are with the rules and the rule language. So I just wanted to make sure folks kind of understood that a lot of what you'll see, if you literally just go get the text of 42 CFR Part 2, won't be what you see on screen, because a lot of this comes from the commentary that exists in the explanation of what ended up in the final rule in this round of changes. So just quickly, this round of changes for folks who maybe aren't following as closely is really what SAMHSA did to modify 42 CFR Part 2 around the most recent requirements that it had to make changes to this rule because of the CARES Act. The effective date of this is April 16th of 2024, so it was 60 days after it was published. And the compliance date is 2 years, so it will be February 16th of 2026. I just wanted to put this out, this little screenshot or this little screen grab from the rule to just tell us that for those of us who've been doing this a really long time, you kind of feel like you made it a little bit if your acronym shows up in SAMHSA's rule, like they know that you exist and they actually recognize it. So in the acronym list, APCDs are listed as, an actual thing that SAMHSA talks about. So I just thought that was kind of, a point that we've made it. And if you search the rule for APCD, you will see the places that we've pulled out where they are very specific about reactions to comments that have come out of the APCD community. So, for those of you who get excited to see yourselves in print, there you are. Even if it wasn't what you wanted them to say. Okay, so a couple of areas of interest. I'm not going to read these all out to you, except to tell you that these are particularly important pieces of language, perhaps to the work that you do. And again, we will send this out, and there are page numbers here, so you can go back and read this, what we have on screen, and the context that sits around it. But for all intents and purposes, one of the major revision sets out of this rule was aligning 42 CFR Part 2 to HIPAA. And you see that in the very beginning of the language, which is this rule really was to set a number of requirements around substance use disorder data to those requirements that exist around HIPAA for other healthcare data. And there's references to this all across the document. One of the things that I wanted to call out very specifically is there was a question, or there were comments that were made to SAMHSA in its comment period when they released the notice of proposed rulemaking around the ability or the inability to use the safe harbor protections for things like APCD programs. And so I just wanted to pull out this language that was very specific to APCDs and HIEs and other data programs that, in fact, they did not make specific changes around giving safe harbor protections to APCDs because, and you can all read this, but it's just essentially what they say is the safe harbor isn't the right approach for these, that there are other aspects of the rule that address when and how APCDs can or should be able to access data. So I just wanted to call out, I know in previous conversations that folks have sort of said is like, doesn't safe harbor apply or couldn't it apply? And I just wanted to note for everyone to call out here that it's a very specific reference to safe harbor and APCDs and why SAMHSA, again, did not make changes to the rule specific to that. So through pages, starting on page 12474, and then this, I think it's like the actually next 5 pages, the next 3 or 4 are the most important, I think, to the APCD side, is this summary of major provisions. What we've pulled out here are those aspects of this that we think, again, are the pieces that are most relevant to the APCDs. And what's bolded here are certain sections, 2.11, 2.20, and a couple of others that we're going to dig into a little bit more in a couple of minutes, because these are the pieces that are most directly tied to APCDs. But we would encourage you to potentially take a look at some of these other sections. We would encourage you to read the whole thing, but we would encourage you to think about some of these other sections in addition to the ones that we're going to talk about in a little bit more depth, because there could be other things that are within those that might be relevant, even if they're not as clearly associated with the APCD side. So for example, section 2.2 that talks about the purpose and effect. Again, there's a lot in there that talks about the intention of this rule and what it's set to do and what it is set to protect, including definitions for use and disclosure and the HIPAA privacy rule. So again, I would just sort of say that 2.2 has some interesting potential applications that might be not as direct, but sort of the full course of work that folks do. There might be interesting and important pieces of information there. We're going to talk in a couple minutes about at least one or two of the definitions that are clarified in this rule that could be important to folks here. There is a section about relationship to state laws, and I'll pull a little bit more of the language around that. There aren't actually significant changes to that, but there again in the commentary, there were requests that were made in the comment period to try to give state APCD some protections under this section, and we'll see how SAMHSA responded to them. These two sections, 2.23 and 2.31, again, are not as closely related, but I bring them forward because as you sort of see what consent documents may or may not be driving how lawful holders are handling APCD data, it may be important for all of us to kind of get a sense of where a patient can and cannot make requests that their information is not shared. So there are parameters in 2.23 around how a patient can make requests for their data to not be shared, and then that could be important as we go down the path and we sort of hear about written restrictions that lawful holders will make based on an individual person's request to not have their data shared. And then similarly in 2.31, there's a lot in there around the consent requirements and authorization. And again, a lot of what this rule does is aligns the authorizations and the consents and the disclosure rules for 42 CFR Part 2 to HIPAA and HIPAA regulations. So again, for those of you who are working in situations in which your rules reference HIPAA as the guides, a lot of that is now replicated in the 42 CFR Part 2 rules. Really, where we're going to spend most of our time is in 2.53, which is the management of audits, financial audits, and program evaluations. For those of you who might be newer to this space, it was back in 2017 when SAMHSA made changes to this rule, and then again in 19 and then again in 2020. Particularly the commentary language really kept pointing to allowances under 2.53 as the ones that would really be the umbrella under which states can get access to 42 CFR Part 2 data for their APCDs and their other data programs. So we're going to spend a little bit more time talking about that. The comments that we sent in as the council, and I know were replicated by a lot of state agencies, were around this 2.53 section and suggestions for changes in 2.53 to strengthen it to allow states to access data in a more streamlined way, or at least with fewer questions. And I'll share a little bit of the comments around that SAMHSA shared. And then 2.54 is around the disclosures for public health. Again, a number of state data programs sit under their public health authority. So we wanted to bring that one forward as well. But again, you know, the public health disclosures really exist for de-identified data, and we'll see a little bit more of that. So I'm going to stop there for a second and give people an opportunity to ask questions or make additional comments that they may have based on any work that states have done digging into this for their own operations before I jump into the next couple of slides. Okay, all right. If nobody asks questions, we're going to do this really quickly and you're going to get sick of hearing me talk. So, content area of interest number 1, 2.11. So this is really in the definitions section that I mentioned. So, so there were a number of definitions that were redefined or clarified in 2.11. What I wanted to highlight for folks is this sorry about that, is this section here, in that they were much more specific of patient identifying information in this rule, again, to align it to HIPAA. But the reason I say that that's important, particularly for health data programs, is that if you are going to say that you're only collecting de-identified data, what constitutes identifiable information is much more explicit in this rule than it has been in the past. And so I know a lot of states have solved for acquisition of the 42 CFR Part 2 related substance use treatment data by getting de-identified data. And there was not always complete certainty about what constituted the de-identified data. And this rule really does explicitly say, well, it doesn't explicitly say, it names certain fields and then it leaves this or similar information clause. So what is up here is the text that exists in that early commentary part of the final rule that was published in February. And then in the actual rule text, which is on this page, further down a couple, 100 or so pages later, the text that exists within the actual final rule identifies patient identifying information, name, address, social security number, fingerprints, photographs, or other similar information by which the identity of the patient can be determined with reasonable accuracy, either directly or reference to other information. So they really did offer a actual definition in the rule itself, in the definition section 2.11. So this is 2.20, which is the relation to state law. So one of the recommendations that came from the commentary, which is the first paragraph, a state agency requested express permission within the regulation to permit disclosures to state data collection agencies as part of this new law. And a state agency requested that the final rule clearly authorize state agencies to maintain repositories of healthcare claims and, sorry, I cut that off, my apologies, and discharge data. The response is the second paragraph, which for all intents and purposes, SAMHSA said we can't do that. So there's no provision was proposed in the NPRM pertaining to APCDs or MPCDs, and thus there is no basis to add such a provision in the final rule. So I just wanted folks to know that that in fact there are no new provisions in this that are directly tied to state law. So Helen had a question. I just want to pause here for a second. Can you comment on the problem that state APCDs face? Sure. Thanks, Helen. I just jumped right in like, hey, here's this thing that we've been worried about for a long time, and here's the new rule, but we didn't actually talk about what the actual thing is that people have been worried about. So thank you for the reminder. Yeah, so essentially, 42 CFR Part 2 protects data related to information related to people who receive substance use disorder treatment. And when 42 CFR Part 2 was revised in 2017, I think it was, that revision really created some turmoil in the APCD and other health data community because those folks who held the data as lawful holders, and in this case, largely the payer community, felt as though they had obligations to protect that data and not share it. So what we started to see happening on the APCD side was that some carriers said, we can't share any substance use disorder treatment related data because it's protected by Part 2. And some even went further to say, we can't share any data about anybody who has had substance use disorder treatment because we can't figure out what part of their treatment is from a Part 2 provider and what part of their treatment is from not a Part 2 provider, because the Part 2 who is obligated to protect data under this rule are providers who receive federal funds under SAMHSA's direction. And so it started this path of data being held back from state APCDs related to substance use disorder treatment because the payers said, we can't figure out who our Part 2 providers are. And over the course of several conversations, including some NADO annual meetings, we had SAMHSA folks come who basically said, the burden of knowing whether or not data are protected by Part 2 is the provider's burden, not the payer's burden, but the payers still sort of felt as though they would be held accountable if they redisclosed these data by submitting it to state APCDs. Over the course of the last however number of years, there have been additional revisions to the rule and trying to really help, trying to really get SAMHSA to help the whole community understand what is allowable under Part 2 and disclosing of data. There was preamble language or commentary language in 2020 that was fairly explicit about how state APCDs have a function that fits under the allowed uses of data, but it was not explicit enough for some data submitters to feel as though the legal risk that they had in submitting data was protected. So, so we've been working with SAMHSA for many years trying to get better clarification of that. So again, the real burden, the real problem here was that there's a lot of uncertainty about the allowance of these data to go to state APCDs. De-identified data is not protected. And so many states solved this issue by getting de-identified data. And then there are other states whose APCDs do collect some of what are considered the identifiable fields, and they have had long-standing issues trying to access these data. That's my summation. I welcome anybody on the call to join in and clarify and add to that if you want to. Okay, thank you, Helen. Sorry I jumped right in. So all of that was to say that 2.20 in the relationship to state laws was basically SAMHSA saying, and again, this is not, I'm not a lawyer, I have no legal training, so this is just my summation of this, which was there was a hope that this section of 42 CFR Part 2 could say that in relation to state laws, 42 CFR Part 2 defers to state law and allows that state law that requires data collection to allow data collection. And basically what SAMHSA says is we don't have the authority to make that kind of reference to state law in this kind of rule. So that did not, so the 2.2 in the actual final rule is not changed in any way. That's important to this group. 2.53 is really the biggest, I think, area of interest. And this is the audit and evaluation section. So again, this is if you were going to start with the most important part of this 160-page document, I would start here at pages 12566 through 12568, because this is the place where the comments that that we made and that many of you all as states made are reflected in the summary that SAMHSA put together of the comments that they received. And obviously their response is here as well. So, you know, the way that 2.53 is described is it permits a Part 2 program or a lawful holder. So in the case of how most state health data agencies operate, we're really talking about the lawful holders here, because the Part 2 program is the actual service provider, but the lawful holder about that information is the payer. And 2.53 does say explicitly, you know, that the lawful holder can disclose patient identifying information to an individual or entity in the course of certain federal, state, or local audit and program evaluation activities. I wanted to emphasize one other comment that exists in this section that is, you know, potentially continues to be really important to us, which for all intents and purposes is SAMHSA saying we might still put some guidance out around this. So this italicized section basically says, we appreciate the comments and provisions under this section and may provide additional guidance after this rule is finalized. Oh, sorry. I think I put that text in twice. We'll clean this up a little bit before we send it out. Sorry about that. It was a lot of text to try to fit on this page. So basically, what we have been asking for SAMHSA for since at least 2020 has been to leverage their ability to create sub-regulatory guidance that can be more explicit than the rule can about how state APCDs should be able to access this data for a number of state operation activities. Sounds in the way that this is written that that is not an ask that we should stop making, that they still believe that there's an opportunity in their sub-regulatory guidance process for that to happen, and that they may actually still be using that. However, you know, even before that, it does indicate that a Part 2 program can disclose patient identifying information to federal, state, or local agencies and their contractors when mandated by law, or if the audit and evaluation cannot be carried out using de-identified information. So there is a burden of indicating why de-identified information doesn't work for the causes that a state might have. And further goes on to say that that government agencies are permitted to obtain Part 2 data without written patient consent for audits and evaluations, and basically says that is a very broad definition. Audit and evaluation, there is not a strict definition of that, and it can be anything from, you know, actions or policy changes that are aimed at improving care. So it's not a strict definition. Audit and evaluation is not a strict definition, which is important because in earlier years, there were folks who were sort of saying, well, audit and evaluation is a very finite thing. And basically what SAMHSA said is that is not our intention. Our intention is that audit and evaluation is a very broad definition. So, you know, for all intents and purposes, what SAMHSA has continued to say in the commentary language and in the changes to the rule text is that state APCDs and all the comments that we made about being able to access those data do exist under audit and evaluation, that those allowances are in the rule to date, And they made pretty minimal changes to the actual rule text associated with that. So what you see on this page is the actual rule text, not the commentary, but the actual rule text that are the changes that are happening for 2.53. Interestingly, around this, I think there is still remains a question for state agencies around that redisclosure component of these data. So if you have a data release process, the the authorization for redisclosure is a little bit harder to understand if you are releasing patient identifiable information, which I don't think most folks do. But I just highlight that as something that you should work through and be very cognizant of, because this is the rule text on the bottom part here, is that the agency cannot disclose patient identifying information for any purpose other than the audit and evaluation purposes within the organization. I think this might be the last slide, which is of summary changes, which is just in the area of 2.54, which is the public health disclosures. Again, the public health disclosures are limited to using de-identified data. There was a comment in that was submitted to SAMHSA asking for that public health purposes, that data disclosed for public health purposes goes beyond de-identified data and actually moves to identifiable data as well. And that was this comment here. And basically the response that SAMHSA said was, we don't have the authority to do that. That our authority to allow for public health disclosure is limited to de-identified data by statute. So again, that was not an allowable change that was requested. So that's all I have for slide comments, and we are happy to take questions or facilitate conversation amongst any of you who are also looking at this rule. And I promise, I warned you all that it was going to be an incredibly boring, text-heavy presentation, and I fulfilled my warning, and I apologize for that. Question is, does this apply to all the data already collected or data collected as a specific date? So I believe, again, this is, I'm not a lawyer. So there aren't significant changes to, in my opinion, there are not significant changes to 42 CFR, certainly from the 2017 rule out of this rule change. So I don't know that there are specific obligations that become effective April 16th that would change how a state handles its own existing data resources. I think the way that this reads, again, if you were me, is that if you were able to get resolution with the submitter, all of the data that they would have around substance use disorder would fall under this. It's not sort of from here forward. It's all of the data around this issue that one holds. I don't know if that answers the question. Hi, Karen Lee. Long time no see. Still don't see you, but long time no hear your voice.
Exactly. And I'm not going to show my camera because I'm a hot mess, but good afternoon,
Sorry.
everybody. And Joe, thank you so much for, and Charles, this presentation. Unfortunately, I feel like it's not what we had hoped for, and it really doesn't change a lot. But I wanted to share with folks that in anticipation of this being the outcome, Maine made the decision last year to move forward with creating a structure in our claims data collection rule that lays out the collection of or the requirement that payers submit to us de-identified substance use disorder data. And I'm really happy to say it went through a public rule making process. We got feedback from payers. We made some adjustments to what we had originally proposed. And it was adopted as amended unanimously by my multi-stakeholder board, which includes payers. So I'm happy to share that with anybody. Charles, I can send that to you. I don't know enough about how the CDL is structured, like if that's even, a potential. But, I just wanted to share that with everybody that that's something we've done. And, that was really based off of our user community saying, look, at a minimum, although it's not ideal, de-identified SUD disorder data is better than nothing. So we've moved down that path, and I'm going to, embark on a journey this year to work with our Department of Health and Human Services to try and come up with a state law that allows us to access identifiable SUD data to help support work that the Department of Health and Human Services is doing around opioid work that I know all of our states struggle with, right? And some other things. And if there are other folks on the call that are interested in pursuing those types of, sometimes I think having a smaller group discussion that's focused, we might be able to help each other. But I'm going to move down that path because I think if maybe what has come out of the changes to 42 CFR is just sort of an underscoring that is allowed.
Yes.
That you
Absolutely.
just need to set that structure up. And so I think we need to figure out, and if there's anybody who's already done that, I would love to leverage what you've already, implemented. So just putting it out there, if anybody wants to reach out or shoot me off an email or drop something in the chat, that would be greatly appreciated. And again, thank you for putting this together. It's really helpful.
And I will just say, Carolee, I think, that is a really smart approach. And, in my read of this rule, and having read the 2022 version as well, what I'm reading in that is, all of those uses that states have to try to make the SUD system better in a very broad way fit under this allowance that state agencies have to get data. Period.
And I should also add that we will start collecting the de-identified SUD data beginning with January 1, 2025 submissions. So, we were giving the payers some time to get their system set up. And again, happy to share that if that would be helpful.
I think that'd be great.
Yeah, that would be great. Thank you.
Question. Was there another hand up? Joanna? Hey, Joanna.
Hi, this is Joanna Duncan from On Point. Thank you for doing all of this today. This is such an important topic. And one thing I wanted to offer is that we see a very broad range of who submits this data and who doesn't across our client base. So it's not necessarily a one-size-fits-all type of challenge, I think, depending on who your submitters are and what proportion of your population those submitters are. So I encourage you to take a look at what you're getting already. You might be surprised at how much of this data you're already receiving.
Yeah, thanks, Joanna. And I will say that particularly in 2017, we really felt like it just was very confusing for folks. I mean, like payers didn't know if they could or they should submit. You know, some states were very strong in their response to say, no, you know, we still have the authority to do this. And other states were much less certain about how to approach it. And so I think, you know, we have seen a lot of variation in there. So thanks for that reminder, Joanna.
Yeah, and maybe one just add to that is, you know, in our Medicare data and our Medicaid data, this is usually very complete. And so it's really that commercial population that I think is struggling with that definition and where do they fit?
And thanks for bringing that up, actually, Joanna. I didn't put this on here because, you know, I'll share with you all really quickly. And actually, I'm going to share the screen again. And I will just say that one of the things that we did in anticipation of, you know, trying to pull out the information that we needed was we pulled the rule into a Word doc and added some highlighting of the things that we thought were most important. If anybody wants this version, we can send this out too. Like, this is just our own highlights. So if y'all think that's helpful, by all means, let me know. I'm happy to share this also. But I apologize for the scrolling. What I wanted to show you all in this is that this whole, when I say focus in on 2.53, it is because, apologize, I wish I had remembered. I can't remember on my own presentation what page this is, but it's late. The 2.53 section has a lot of explanation, much more than we put onto these slides in response from SAMHSA on it. So it might not even be worth doing this now, but we can share with you the highlights. Oh, there it is. Because you know, from as the page indications note in the slides, 15, 1, 2, 5, 6, 7. This page all the way down through this is basically the commentary about the entire application of 2.53 to state data agencies. So there is a lot there, and certainly a lot more than we shared on screen. So if anybody, you know, wants this this version of the rule, I'm happy to share it. I had to put it into Word because the PDF is signed and not highlightable. So if that's helpful, Sylvia, and then we can go to the question that's in the comment.
Yes, my question is to the state of Maine. I wanted to know whether there was buy-in from the carriers on the de-identified data in terms of submitting zip code at the medical claim line level, because the states have the burden based on CDC standards of targeting their prevention funds based on dates and zip code related to diseases when calculating disease rates.
I will have to go back and double check. I feel like we had to remove the zip codes. But I will go back and double check, and I'll send to Joe and Charles if you guys want to send out to everyone, like what, because it's our rule is pretty easy to follow, and it will show you what's been excluded versus what's been included. So yeah, I mean, it's not great, but I think until we can figure out how to get the identifiable data for the research or the policy, whatever the right language is in 2.53, for that intent, we're going to have to, you know, go with sort of this real bare bones de-identified data set.
Okay, thank you.
And I just want to highlight again, I mean, I do think that that's actually one of the places where the definitions section changes does help a little bit here. Because this 2.11 does have this much more, I mean, I know it has this term that says similar information, but at least it does provide more definition in the definition than we've seen in the past from SAMHSA directly about what does patient identifying information mean in this context. So this is, again, that's in the slides that we'll send out. And And Christina, to your question, so in the chat, you know, I think there are a number of states that have gone with de-identified data and with that hashing routine. New Hampshire is one of those states that has always had this hashed ID. And so, you know, basically they had a, if I remember correctly, and if there's anybody, I can't see all 150. Mary Fields is on the, I see Mary Fields' name. So Mary, you can jump in here if I'm getting this wrong, or if you want to clarify or add to it. But you know, even in the 2017, I think, rule change, New Hampshire put out guidance to its submitters basically saying we're a de-identified data collection and this doesn't apply. And I don't think had a ton of pushback on that, and have done a lot of reporting around this, if I remember correctly. And Mary just went off mute, so she might tell me I'm wrong.
You're not wrong.
Or I'm right, which is even better.
So we went a little further than that. We put out a message, but we also met with all the carriers. And the fact that we do de-identify through a preprocessor before the files are even sent to our vendor really provided that comfort. We've had no loss in data because of that. Risk is another topic, but as far as this, we're good.
Okay, thank you both so much for your help. I appreciate it.
The question is, does this 42 CFR apply to hospital discharge data collection? We haven't heard it as much on the discharge side of the house. Frankly, I don't know why. Other than, again, you know, a lot of the discharge data systems don't have those direct patient identifiers at the end of the sort of process of bringing the data together. And so I don't know if that's why, and or because the hospitals don't see themselves as substance use disorder treatment providers in the way that a Part 2 system would be. But I'll be super honest with you, I've never quite understood how that didn't apply as much. But again, you know, that's not my area of expertise as much. I will say that there was this, as I mentioned before, and I apologize, it was cut off. I did fix it while we were talking, just so I didn't, when this gets sent out, I didn't send out the one that was incomplete. But there is language in, I think, the state law provision, the 2.20 part, that does make direct reference to how the state law around hospital discharge data doesn't have any applicability in the relationship to state law section of 42 CFR Part 2. Oh, okay. So, is that Efren? Farin? I apologize. I'm not exactly sure how to pronounce that, and I'm sorry if I got that wrong. But does indicate that there's Oh, go ahead, please.
No, I was just saying you got my name right the first time you attempted, so.
Oh, okay. Well, would you like to talk about your discharge data system?
Oh,
comment?
I mean, honestly, I'm kind of curious, how, so, you know, for these standalone behavioral health hospitals, we do not receive that data directly. When you have these larger hospital systems that operate inpatient clinics or inpatient units, I think that we are still getting that information, but I'm not entirely sure if the facilities may be kind of holding that piece back.
Yeah.
I mean, I think it's tricky, like you mentioned before, kind of what is a Part 2 provider, because lots of times people are in the hospital for something completely unrelated to mental health or substance use, but if they've got that as a co-occurring disease, it's gonna get included. And I don't know that like HIM people are pulling that back.
Right.
I think there may be some inconsistencies there.
Yeah, and again, I mean, the Part 2 provider is defined by receiving certain federal SAMHSA funds. So it's entirely possible that the hospital itself is not, that they're not funded in that way by SAMHSA, and therefore it doesn't apply. So again, this isn't, it's not all behavioral health and substance use disorder treatment. It's this, a Part 2 provider is defined as a provider that receives certain SAMHSA funding, and that's why this SAMHSA rule applies to them. Any other questions or thoughts? Charles, I will send to you the slides that I just fixed so we can distribute those out to everybody that was on your list. And again, I'm happy to share the Word doc where I highlighted the things that I knew I wanted to pull out for this group. But, there's nothing special about it other than it's converted to Word and has a little highlighting in it.
Yeah, I can share that around too.
Yeah, and Alaska, it said, so Richard says, Alaska's program sounds similar into what Oklahoma's experience was. So again, I think that might, I think the hospital piece may really be tied to how a Part 2 provider is defined by SAMHSA.
He's saying that they do get behavioral health data.
Right. Again, like I just don't know what truly makes a Part 2 provider, which is not everybody.
Yeah.
Not everybody who provides these services is a Part 2 provider. And we, I think, Charles, maybe we could try to find somewhere way back in the day. I think it was many of you may have been there. There was a NATO conference and I'm pretty sure it was in DC. I'm pretty sure we were at the Omnishorum, and SAMHSA came in and did a presentation, and they had a slide that was, what is a Part 2 provider? And it really helped, I think, everybody kind of understand a little bit about to whom the rule applied, because it isn't necessarily everybody who does substance use disorder treatment.
And it may
So
in part have to do with hospitals not needing explicit consent for the use of their data, as opposed to insurance carriers for certain type of data. It might be consent related.
True, very true. Good point, Sylvia. Okay. Yeah, it's a good point, Richard. I mean, really, the fact that you leave it up to the reporting facility, that was also SAMHSA's point in this presentation, if I'm remembering it, which again, the burden of knowing if you're a Part 2 provider is on the provider, not on sort of the rest of the universe. Janice?
Hi. Yeah,
Hi.
my understanding, and I know there's some payers on the call also, was that, if you're the provider, like you said, you would know whether you're receiving SAMHSA funds or not, as opposed to a payer. They don't know which of these providers are receiving those funds. And so they're playing it safe as far as withholding that information or not reporting it.
Right. Right. Yeah. And again, I mean, I think what SAMHSA has sort of said out loud to us in the past, and I think is reiterated in this, touched upon it in the 2020 rule and tried to reiterate it here, is that, much of what states are trying to do as a state function to improve the healthcare system fits under what they would say is their audit and evaluation, and sort of give folks the protection that they felt like they needed to share this information. I really do think that they tried to reiterate that here. And I do think that there's some the reference that they might still use sub-regulatory guidance to add further clarification for that is a little bit encouraging, because I do think that that's a mechanism for them to be even more clear than they can be in the rule. Charles, anything else we need to do with this group besides get them these slides so everyone can go look at these references?
No, I think that's great. Yeah. So let me say thank you, Joe, for leading the conversation.
Sure.
And let us know. We'll circulate those documents. Let us, everyone out there, if you have questions, feel free to reach out.
All right.
Take care.
Thanks, everybody. Have a great rest of the day.
Thank you.